So this was a very interesting session. I'm going to try to summarize what just happened here, including the debates. The provocative thought process going on and what's the ideal shock score and severity score and all that. I have no relevant disclosures. We've talked about the definition of shock earlier today with Dr. D'Alessandro, yesterday with Amanda Vest, and the clinical trial definition of a systolic blood pressure of less than 90 with evidence of organ hypoperfusion. It is essentially a clinical and biochemical evidence of tissue hypoperfusion. This definition, however, in this definition, are we losing context and creating ambiguity in the pursuit of simplicity? That's what we're trying to deal with right now. Are we missing some of variables that we, as clinicians at the bedside, need to put in, to plug in, to understand more about the severity of shock that we're dealing with? I stole this from Dr. Hollenberg yesterday. Cohort A, B, and C. We know cohort A, those are going to survive in patients in shock. Cohort C are not going to survive no matter what. The issue that we're trying to deal with is how to define the severity of classification in cohort B. Who's going to survive? Who's not going to survive? What kind of therapy are we dealing with? So what variables am I talking about? So we've heard the talk about the severity scoring system from A to E, A being at risk and E is an extremis. That was published by Sky and discussed multiple times today and yesterday. And Dr. Jenser also looked at the inpatient mortality in the ICU in a retrospective manner and showed that there is a difference between stage A and stage E. And we looked at it at post-discharge mortality, and we can see that clear distinction from stages A to D and E. But again, this is a severity scale. This is a quick way of assessing patients early on, whether they're an extremis or not. But I can argue that the shock is more than just that. We understand that shock is not created, treated, or prognosticated equally. And we know that it comes in different flavors, and oftentimes mixed shock is also seen at the bedside. So if you look at the onset, this is a poorly understood concept when it comes to the time in shock management. We know that it's a hemodynamic problem that progresses quickly to a hemometabolic problem. And we understand that once we have end organ dysfunction, that prognosis is poor. We do understand that. The question is to try and catch patients early on before they progress into this hemometabolic problem. And that should be taken into account when we're dealing with patients who are presenting in shock. We understand that shock is the final common pathway of multiple different disease processes. It's not one disease, and treatment can vary from one patient to another. I'll give you a few examples of patients. This mouse is not working here. Can you play the first video? This is a patient who basically has reduced EF and came in with an MI, and it was a mitral clip embolization to the ostomy of the RCA. This is, unfortunately, the videos are not playing. This patient had root thrombosis in the setting of and left main thrombosis post LVAD implantation. This is an acute myocarditis patient with evidence of giant cells. So management differs from one patient to another, even though they're all presenting in cardiogenic shock. The questions that are unanswered, the kinetics of shock, how shock behaves from one patient to the other. Should we offer full MCS support, more than 50% of index flow for that patient, or should we give partial support and then escalate as needed? The question to that specific answer has not been looked at in a clinical trial. Whatever approach we use, whether it's full support and de-escalate or partial support and escalate, what is the time that we need to give to see if our therapies are adequate or not? And talking about markers alluded to earlier yesterday and will be discussed later today is what are the parameters of adequate resuscitation? Are we looking at SVO2? Are we looking at lactate? Are we looking at blood pressure? What are we looking at? And then the critical question when we get the patient to a shock center, is a stage C patient who's stabilized on low-dose inotrope the same as a stage C patient who stabilizes on VA ECMO? So if you put all this in action, the shock, the severity, the hemodynamics, the onset, the cause, and kinetics, we can potentially come up with a more comprehensive way of looking at shock, again, in a shock center. looking at the sky staging from A to E, but also looking at the hemodynamics, what kind of flavor of shock are we dealing with? What's the onset? Are we dealing with an acute, subacute, or chronic? Are we dealing with mostly an ischemic event, ischemic with a complication, or a non-ischemic etiology? Are we dealing with RV failure predominantly? Are we dealing with an electrical issue as well? And we're looking at the kinetics. Are the patients stabilizing on the therapy that we're providing, or are they sliding? And the degree of support, are we giving less than 50% or more than 50% of index flow with MCS or with just use of inotropes? And this is what was alluded to in the previous talk about, response to therapy score. The two questions that I asked earlier, are we losing context in the pursuit of simplicity? But with this score, are we creating context but also creating ambiguity by adding complexity to the scoring system? And I would argue that this would be utilized in a shock center rather than a non-shock center to look into this patient a little bit more in detail. And the question is whether these variables that we looked at, are they gonna be a better way of assessing risk moving forward for these patients in a prospective manner or not? That's it. Thank you.
I'd like to start opening the discussion by asking a question that we're looking at acute hemodynamics to identify the severity, and we've all talked about lactates. Are there, and this is for the panel too, are there other measures that we could look at for tissue ischemia that are different than lactate that might be more sensitive or might be more quantifiable? So serum X is something, and then 2X, the patients are worse because they have more ischemia. Are you aware of anything like that we could look for that could be perhaps a little bit more quantitative than lactate?
We do have an entire session this afternoon talking about the different parameters, including SVO2, lactate, tissue hyperperfusion, and all that. I think there will be a lot of exciting discussions on that.
Yeah, when I see a patient at the bedside the next day, I examine their legs to see if they're cold, and I look at the Foley bag. And, we don't talk about that, but urine output after whatever you do is really crucially important. And if they're making urine, they're going to do well. But we never really quantify that in any of these scores.
Correct. So that was a phenomenal talk. I love this. I took a photo of it. I don't take a lot of photos. That's just phenomenal. There's some literature in the septic shock arena looking actually at plasma renin levels. And there's at least one small study that suggested in those patients, the septic shock patients, that plasma renin levels actually outperform lactate as a predictor of mortality. No data in cardiogenic shock, and it's entirely possible that it's totally irrelevant. But the reason that it could be relevant is, given how much we antagonize the renin-angiotensin-aldosterone system, but now there's also drugs that move the other way where you can actually agonize that system. And so there's potentially the targeted therapy that could be done. So hopefully that's relevant.
Dr. Jumean, so two questions. One is, can scores that have been used to prognosticate patients at the time of admission be reliably applied throughout the hospitalization? I.e., does an Apache 2 score of X on day of admission mean the same as on day 7? Or does it matter how you got to that and what has been going on? And second, how often do you think these scores should be checked? Every 6 hours, every 8 hours, every day on rounds, anytime there's a clinical deterioration? Because part of the idea is that these scoring systems help us identify who's at risk before we see the consequences of that risk, right?
That's a very good question. I think there's no one size fits all. I think it's, when you're a clinician at the bedside, you can talk about scoring. I think we have the gurus of scoring systems here in the room today, but at the end of the day, it's basically what you're doing at the bedside. You're sitting at the bedside and looking at the clinical response. You're looking at everything together, and in your mind, you're putting all this together and making a decision one way or the other.
That gets back to the purpose of what is the score, as we just heard from Dr. Naus. I mean, are we treating the score or are we treating the patient? That we're going to wind up with that kind of thinking as well. And it goes back to a comment earlier about the simplicity and the ability to make that score determination quickly, the accuracy of the score, the variability of a score based on who is making the determination. There's an interoperator variability there as well. So there are a lot of issues that still have to be worked out.
I think all of us are trying to quantify, make the art of medicine into science of medicine. That's where we are struggling. Like Dr. Neil said, we all look at urine output. whether you put a tandem heart, ECMO, pressures, if the patient starts making urine, you know this guy's going to do well. We all know intuitively, if you see a patient, whether I need to come back in half an hour to see this patient again, or it's okay, I can see in the morning and the house staff can give me a call. But we are not able to quantify what is it that we are seeing that we are making those decisions. So to that, Dr. Naus's presentation was so illuminating. I mean, it was one of the best talks I've heard in how to classify. I think we have to take a lot from that wisdom that they have gone through and not rediscover the wheel, but trying to translate those intuitive clinical decisions that are made into scientific numbers which are reproducible and can be taken across the system. I think that's the challenge we have.
Perhaps computers can do better?